A lot of what I'm going to present is actually, or has already been presented by Dr. Rubin and Dr. Wilkie. But I'm going to cover two things. So first is an analysis that I just did with a group of oncologists and some folks who you've already heard from, including Dr. Rubin, looking at the US Cancer Statistics Database, specifically pulling out patients who have EHE and other malignant hemangioendotheliomas, and then also talk some about surveillance strategies and differences in imaging modalities that many of you have heard of. So first, looking at the Cancer Statistics Database, so we polled essentially all of the cases with hemangioendothelioma, and one nice thing about this database is that it represents actually about 99% of all cancer diagnoses in the US. And if you look at the graph on the left, so that's all of the cases, and you can see there's about 100 patients diagnosed in the US per year with hemangioendothelioma, and we think most of those are EHEs. The blue bars are the ones that we know for sure were EHE because that's how they were coded. And then on the graph on the right is the incidence, and really the bottom line from that is, as you all know, this is incredibly rare. So really less than one case is diagnosed per million people. The distribution was a little bit different from what we expected to see, where there was a slightly older skew of the patients. So most commonly, this is diagnosed in people in their 50s. So a little bit older than the data that's been published, which Dr. Wilkie presented, showing a median diagnosis age of about 40. And then also, we saw an even split between males and females, which again is a bit different than what has been published. The distribution is, as you might have expected, where one slight difference is perhaps more patients with a diagnosis of a skin or soft tissue primary EHE, but about a quarter of people had a liver primary tumor, almost 20% had primary disease in the lungs, another 13% had disease in the bones, and rare patients had primary sites across the rest of their body. There was a question asking earlier in this session about primary cases in the brain, and we actually did see 1% of these cases were identified in the brain, which translates to about one person in the whole country per year. We had survival outcomes, which essentially is how long did these people live, for a smaller subset of the patients from a separate database called SEER, which is a bit more comprehensive and has some extra data points. And 417 of the almost 2,000 people who we had identified with hemangioendothelioma also had survival outcomes. And one thing that was a bit surprising was that there seemed to be a subset of people with especially aggressive disease who didn't even survive 2 years. So one important thing to note is that, of course, everyone's different. And this is aggregate data, so collecting everyone who has been diagnosed with hemangioendothelioma. But that was a bit surprising to see because we think of this generally as such an indolent disease that can just sit and not change at all for long, long periods of time. But still, over 50% of people were alive after 5 years from their original diagnosis, which is consistent with what we all know, where many patients with EHE or hemangioendothelioma do have indolent disease. And then when we looked at the diagnoses by primary site, it did appear that people with primary tumors of the lung seem to have a worse prognosis. And that is, again, consistent with what we think, especially with pleural disease being known to correlate with a somewhat more aggressive presentation and course. We separately looked at the extent of disease. So people who had localized or regional disease had somewhat similar outcomes, but people who, when they were first diagnosed and entered into the registry, who already had metastatic disease, they did seem to do worse than people who had what was localized or regional disease. And I think just to define regional, so that does include people who have multiple tumors, but within the same area. So for example, someone with several different liver tumors would be considered having regional disease just because they're all in the same organ. There are, of course, many limitations to using databases like this. One of them is the lack of confirmation of the diagnosis, in particular with such a rare disease. And from what Dr. Rubin was presenting, these are often misdiagnosed, where there has been actually there have been formal analyses showing that for really all sarcomas, that central review by a sarcoma-trained pathologist will, in many cases, sort of a surprisingly high number of cases, actually change the diagnosis to a certain extent. And even in one analysis, so about 6% of the tumors that were originally called sarcomas are actually eventually found to not even be sarcoma or something else like melanoma or some other tumor. So it's certainly possible that some of the patients who are included in this database had other diseases. And I think one example that we can almost certainly say existed in perhaps a few patients in this database is something like angiosarcoma, which also can be misdiagnosed sometimes. But we have no way to actually prove that. So we can't go back and centrally look and have someone like Dr. Rubin actually look at any of these patients' pathology. Another limitation is that we don't have any of the molecular data. So of course, we now know that EHE is created or formed because of the presence of certain chromosome translocations or changes in the DNA of the tumors, and at least 2 have been identified. And those 2 have a very different expected outcomes, where the one that we typically associate with EHE, the WWTR Cancer1 fusion, is a change that leads to more aggressive disease compared to people who have the YAV1 PSE3 gene fusion, where those EHEs, if we can still call them EHE, actually tend to have more indolent or better long-term survival rates. So what does all of this mean? So first, the age skew did seem to be a little bit longer, and then also in the first 2 years, we saw slightly worse outcomes, I guess, than we were expecting to see. So one hypothesis that maybe there are people who are a little bit older or who have more aggressive disease who are just treated locally and never even make it to a sarcoma specialist. So maybe people like that would have been excluded from some of the earlier published data. But sort of acknowledging that, and I'll talk a bit more about this in the next few slides, but because of the possibility and the uncertainty when someone is first diagnosed of how the EHE is going to behave, we do more frequent surveillance, especially in the first 2 to 3 years from when we meet someone in the clinic and when they're first diagnosed. But really, again, and you've heard this before and you'll hear it again, every individual is unique, where, especially with something like EHE, where the behavior of the tumors is so unpredictable, really no one strategy works for everyone. And it's incredibly important to have a discussion with an experienced sarcoma provider at some point in establishing what follow-up plans you're going to have, including treatment. So to talk a little bit about surveillance strategies and some imaging modalities, we will use different types of imaging to actually look at EHEs. So one thing that many of you, I'm sure, have gotten is something called an MRI, where we will generally try and include MRIs for sarcomas in the extremities, so in the arms and legs, or in the soft tissue or muscle. So for example, a EHE or a sarcoma in the chest wall will actually want to get an MRI for better resolution of differentiating the tumor from something like the muscle. And MRI is also very good at getting a look at the liver. So even though you can see lesions in the liver on a CT, an MRI gives sort of extra information that helps see, especially some of the smaller tumors. CT is best for looking at lungs. So again, as you know, EHE tends to like to go to the lungs if it's going to spread. We can sometimes see that on chest x-ray. You get a much, much better picture by using a CAT scan. So I always get CAT scans for anyone with sarcoma, including EHE, for looking at the lungs, especially in the beginning when we don't know exactly how the tumor is going to behave. And then depending on where the location of an EHE tumor is, we'll oftentimes get a CT of the abdomen and pelvis as well. And that's a somewhat easier or better way to look at the intestines. and the organs inside the gastrointestinal tract. A PET-CT also is frequently used. They're useful sometimes, but I would say not all the time. The reason for that is what a PET-CT is the contrast or the dye that's used is this radioactive sugar molecule. And things, whether it's a tumor or infection or something that's active, that are using sugar for energy will take up that dye. And then when that happens, it's more or less what we call a hot tumor. So it literally glows the way the image is processed. And you can see just a bright, almost like a yellow light bulb at a very active site of disease. One of the potential benefits is for tumors that do pick it up, then it makes it much, or so it was very nice to use and see because it helps highlight certain areas that might not be picked up with the other imaging modalities. And also it's a way that we can actually do a whole body scan, which in some cases is nice, especially if we want to look at many different body parts all at the same time, or for a tumor like EHE, which is so unpredictable and can spread, in theory at least, to all parts of the body. But one important thing to note is that the imaging with a PET-CT is generally lower resolution than an MRI or a regular CAT scan. So sometimes we'll have to combine some of these imaging types. And then finally, a bone scan is something that some people might have had, where that's especially good at looking for bone metastases specifically, but really doesn't give much information about anything else. And oftentimes I'll sort of substitute a PET-CT if I'm especially interested in looking at the bones, but want to sort of do one imaging test to look at multiple things. So as you've heard before, the lung and liver are very common sites of metastasis. And just to reiterate, CT or CAT scans are the best way to look at the lungs. You can use a CT or an MRI to look at the liver. And again, it really just depends on your specific circumstance, which one might be better for you. I tend to use MRIs, especially for people who have primary liver EHEs, just because it helps to see some of the smaller lesions a bit better, and because there are lots of different liver-directed treatments, you get I think at least a bit better of a picture with an MRI of the liver for those especially heavily pretreated tumors in the liver. But another question is, well, how frequently should we get the imaging? And again, in the beginning, we will generally get the imaging more frequently, so every 3 to 6 months, where I included just a range there because there is no one right answer. It really does depend on how much disease is it already known that you have, how does it seem to be behaving, and there's some variability to how frequent anyone should get scans. But usually in the beginning, I will get them at least as frequent as every 6 months. But then extend that interval out, especially a few years in, if everything has stayed stable or without any further disease. If the original tumor has been removed, then we can extend to annual scans and sort of continue the discussion as time goes on. So just to summarize, there is no clear consensus for what type of imaging any individual patient should get or how frequent. And a lot of that decision-making is based on patient-specific factors. So how quickly does it look like the tumor might be growing? Is someone on treatment? So for someone on treatment, we'll get more frequent imaging to try and assess, is the treatment working? But again, it's very important that everyone with EHE have an individualized surveillance plan, just because these tumors can be so unpredictable. And because it's so rare that we don't have large data sets to truly guide this decision-making process like we do in some other types of more common cancer. So to conclude, there are patients who have indolent disease, there are patients who have aggressive disease, and from the very beginning, it can be actually pretty hard to differentiate who will be in which of those tools, but for surveillance, we at least get somewhat more frequent imaging just because of the potential for more aggressive behavior. And just because one person has one experience, that doesn't mean that's going to be the same experience for every patient. So individualized plans determined in close collaboration with you also, with the patients, and with sarcoma specialists is very important. So thank you very much.